So the largest treatment study in ADHD is still this thing about 15 years old now, which Dr. Pelham was one of the investigators on, called the MTA, or the Multimodal Treatment of ADHD. And what makes this study so interesting, other than the fact that it was very large and done at 6 different sites, so it just wasn't one person's opinion, is that it looked at a combination of treatments. Medication, which at the time was short-acting Ritalin, behavior management, which turns out to be a very intensive packaging of things like our summer program, school-based interventions, parent training workshops, all the things that Dr. Pelham talked about, a very intensive, large package. The combination of the two are basically going back to your pediatrician and getting what your pediatrician would give you, which a practical difference, when you came to the research group, you got a larger dose and you got medication extended throughout the day. The pediatricians at that time in the mid-90s tended to dose just to cover school hours and not on weekends. So it wasn't so much different meds as it was more medicine and potentially a little bit more individually crafted medication regimen, but not different meds. And the question was, which of these would be most effective? Hopefully, could we figure out a pattern so you could match each individual child to the best treatment? It's exactly the question Dr. Pelham asked before. What works better for who? And what this did, before we even get into the results, one of the main effects of the study was that it tended to promote use of medication outside of school hours, especially on afternoons and weekends. So before the MTA, we would traditionally dose medicines just to encounter school hours. After the MTA, this phenomenon of 7-day-a-week medicine came about, in part because of the legitimate recognition that ADHD symptoms exist outside of school and impair social and behavioral function anywhere kids can be. But one of the effects of it was it led to a massive increase in the total amount of medicine kids were exposed to, which we have to recognize as a difference. So all the safety data of growing up on old school Ritalin doesn't necessarily apply to growing up in this century even though it's the same active ingredient on new school ADHD medicines, because kids are getting exposed to much larger doses. And we'll talk a little bit about the research on that and how we have to pay attention to this, and we just can't use the data from the 70s in terms of the safety anymore. So these are the main results. Everybody got better. All the treatments worked. When you looked at reasonably high-dose medication, in terms of symptom scores, it outperformed the behavioral treatment by a reasonable amount. But if you remember, the big emphasis is on impairment, not so much symptoms. So this is a mild victory at best. When you look at combination treatment, more kids got completely normal than kids who got either treatment alone. And you brought the dose way down, which may have significant benefits in terms of tolerability and long-term use. And intensive behavioral therapy worked as well as traditionally dosed medicine that covered school hours. So it's not so much even that medicine outperformed behavioral therapy during the school hours. It really didn't. 8 years out, now the trick is kids weren't in the study for 8 years. They were in the study for about a year to 14 months, and then they went back out to the community and got whatever treatments they wanted to. So 8 years out, we really couldn't see any difference based on what treatment you got. Everybody was a little bit better, but everybody was still largely impaired. So 1 year of really fantastic treatments probably doesn't do a whole lot to change the long-term outcome. And at the end of the day, 1 year of medicine versus 1 year of behavioral treatment probably doesn't make an impact in terms of how much better you do when you're 18. So just like yesterday with anxiety and depressive disorders, we have to take into consideration what are the side effects of the medicine when we compare it to the relative benefits of therapy or counseling interventions. The meds do work quicker. There's no doubt about that, and that can be a plus and a minus. It's a plus for the individual child, but there's been some concerns raised that a quick partial effect may prevent or cause families to lose interest in following through on other things down the road. So this just shows you this visually. Let me see if I can get my colors right. The dotted yellow is medication, and the purple is medicine. These are symptom severity. 2.5 is really bad. 0 is no problem. This is that SNAP scale Dr. Pelham mentioned. You see a little faster decline with medicine. These are months. But you get there. Within 2 years, everybody gets to the same point. You're better. But the problem is, here's a child without ADHD. You're still not there. So we have a ways to go in our treatments to get down to here, where we want to be. And in the long term, the initial treatment probably doesn't make too much difference.
And I would add to that that the analyses at the 8-year point looked not only at the first year, but looked for people who had medication, whether they continued medication over the subsequent years. And the analyses were unable to find that people who had been medicated the entire time were any better off, that is the entire 8 years, were any better off than the people who had not been medicated the entire 8 years. We didn't measure whether people continued to use behavioral treatment, so we don't even know whether that would have made a difference.
So what ADHD medicines can do, and again, we're mostly talking about symptoms, and remember, we'd like to really key more in on impairment, but you will see a fairly large reduction in symptoms for physical hyperactivity, talking too much or not sitting still, large reductions in symptoms for impulsivity, interrupting, or other kind of reckless behaviors, and large reductions in symptoms of inattention, being easily distracted or problems staying focused to someone talking to you or what's in front of you that you're trying to attend to. You will also see some improvements in kind of proxies of real classroom productivity, such as the accuracy and efficiency of academic work, especially in repetitive tasks like math. And you may see some reductions in arguing and other aggressive behaviors, although overall that's probably not quite as a large effect. So there are some real-world improvements in impairment. There's no doubt about that. But our most robust effect are in symptoms, and those don't always translate into how well other people like to hang out with you, whether it's your teachers, your parents, or your friends. What ADHD medicines don't do, and this is important, like I said and you saw in that graph, they don't fix everything. They don't lead to a complete resolution of symptoms. They do not lead to sustained improvements once medication is stopped. At least that's been hard to show, and there's some debate if they lead to sustained improvements even if meds have been continued. They don't typically by themselves lead to improved social relationships. They don't teach kids to be more organized, which is a major impairment associated with ADHD once you get to middle school and beyond. And they do not lead to large improvements in symptoms of other mental health disorders that are common enough in ADHD, depression, anxiety, or substance use. This has been a bit more controversial, but most of the data will agree that the medicines don't increase or decrease substance use much one way or the other. And they don't lead to large changes in parenting practices. There's a little bit of evidence that parents will find the kids less stressful to interact with, but that in and of itself doesn't seem to create changes in parenting practices.
Can I add to that?
Mm-hmm.
I would just add to that remember we showed the slide about school-based functioning and all the problems that kids have in school, including high school problems, being behind, dropout, and so forth. Medication doesn't change any of those outcomes either. And the thought may be that it doesn't change those outcomes because it doesn't lead to improvement in organizational skills, and because it doesn't lead to any changes in academic achievement. So even though when you're an elementary school kid, it makes you do more seat work of whatever you're assigned to do. That's what Jim was talking about with the increased numbers of math problems that you do and so forth. That does not translate to academic achievement on standardized testing such as FCATs. So it doesn't lead to changes in peer relationships or to changes in academic functioning or to changes in parenting, and that may be why it doesn't have long-term benefit, because it doesn't change those three things that, 30 minutes ago we were talking about as the three most important drivers of long-term outcome.
So when it comes down to ADHD medicines, we're still largely talking about stimulant medicines, things like Ritalin and Adderall. And again, remember, stimulants refers to the capacity to increase blood flow or to increase nerve activity, not so much to increase physical behavior. They've been around for more than 70 years now. We're talking about two main classes, methylphenidate, which I abbreviate MPH, or amphetamine-based products, abbreviated AMPH. Almost all other existing modern ADHD medicines fall into one of these two categories. Things like Vyvanse and Adderall XR are amphetamine. Things like Concerta, Focalin, Metadate, Daytrana, they're all methylphenidate products. They have the same exact active ingredient. It's just like Tylenol and or acetaminophen and ibuprofen. You can rebrand it a bunch of different names. You can code it differently. They're slightly different in terms of tolerability and how long they last. It's the same active ingredient, though. So generally, these classes have roughly comparable efficacy, but amphetamine tends to be a bit stronger, that a few more kids may respond better to amphetamine than methylphenidate, although the differences are subtle, and I wouldn't call it a better a more efficacious medicine for every ADHD child. Some respond better than one to another, but the problem is we don't know that ahead of time. I cannot blood test you, image you, take a saliva swab of your genetics with any good reliability yet and tell you which med you'll do better on, although the field would like to get there. We're not there yet. And generally, we'll get a response. You have to remember, a response is defined by a reduction in symptoms. It isn't defined by complete resolution or typically by measures of impairment, how well you're liked and how well you get along with other people and what your grades are. And for people who want really more detailed information on individual medicines, there's a couple of references down here which are very good, but that's really not the point of the individual talk today. These are some brand names, just so you'll see them. And then some of these are available in generic, some of them aren't. But there are a couple different ways you can take these medicines. You can have short-acting pills. This is the old school Ritalins of the world. They work as good as anything nowadays still. Nothing is better in terms of pure effect. And they work very fast within 30 minutes. The problem is they wear off very quickly within 3.5 to 4 hours. Very few kids are in school for 4 hours a day. So that tends to be problematic. It leads to redosing in school, which is complicated and not preferred by many children or parents. So they've largely gone by the wayside for elementary and middle school kids. And then you have different coatings, whether it's a pump or coated beads or even a patch, that allow the same exact medicine to last longer throughout the day. You're literally just changing the shell to get more effect later in the day, not really to get better effect. Because, like I said, plain old school generic methylphenidate works very well. No drug has really beaten that. Same thing with amphetamine. What you dexedrine and dexostat, tablets from the 70s and 80s that were commonly used. All we've done is change the coatings. It's the same active ingredient, whether it's Adderall XR or Vyvanse. They're working on a patch formulation now. So what all these medicines do is they have an impact on dopamine, like I talked about. They prevent removal of dopamine from in between synapses. They keep what little dopamine is there from being in, to make it stay in the right place at the right time. You can't make more dopamine with these meds. So if you're naturally terribly deficient, you're out of luck. You're probably not going to be much of a med responder. And it's probably why we can't get cures. We can't cure. We don't change any of the underlying issues in the brain. We just kind of reroute what's there to make it more efficient. So if you have a traffic jam, you can kind of open up an express lane. But if you pump too much traffic through there, that's still going to get backed up. It just goes a little bit better than before. And that's really the same analogy here. The real key in selecting the medicine, because it turns out, again, these medicines aren't all that different, is to find out what time of day are the kids most impaired by their symptoms. And then you want to pick the medicine that's going to provide the most coverage for that day. Now, if a parent says 24 hours a day, we're all out of luck. But if the morning's a big deal, you want something that works fast. If late in the day is a bigger deal, you want something that lasts long. Traditionally, long-lasting doesn't work fast. It's always a negotiation. There is no one medicine that has a clear advantage across all times of the day than another medicine. But some release more med at certain times than others, and that's how we try to match the med with the child. And again, these are just the different preparations: Concerta, Metadate, Ritalin, Focalin, Daytrana. They're largely similar. It's just the coating that changes. And that changes the duration from 3 to 4 hours for old school Ritalin, up to 12 hours for Concerta, 8 to 10 hours for these other capsule products listed here. The patch is interesting because it lasts as long as you wear it. So if you go to bed with it, you're medicated overnight, which isn't, well, it's hard to go to bed. So you have to remember to take it off. But that's probably the way to get the medicine in you the longest, although you can depatch yourself, so you can unmedicate yourself, which is sometimes problematic. And again, this just shows you different blood levels. Let's see if they're all going to show up. There we go. One more. So again, same active medication. You're having the same effect. You're increasing. This is plasma methylphenidate levels. That increases dopamine release in the brain during certain activities. Just to show you that these drugs aren't any different in terms of what they do, just different in terms of the time of day that they do it. And again, no difference than amphetamine. Amphetamine's a little stronger than methylphenidate products in that it has multiple ways of rerouting dopamine to the point where you want it to go. That can be associated with a few more side effects and maybe slightly more efficacy. But again, over 100 kids, maybe 10% more will do better on amphetamine. It's not like every child does better on an Adderall product versus a Ritalin product. And you typically have a little trade-off in side effect. Typically, appetite loss is a little stronger, and people will report feeling the medication, not in a higher euphoric way, but just a sense of feeling medicated, which little kids tend to hate. Adults don't mind because they like to feel something to believe that it's working. And these are the different preparations. Adderall XR, the old Dexedrine Spancel, the new Vyvanse. Again, we're just changing the coding, and they're trying to put it in a patch form as well. Here's some standard doses. I put these up here only to tell you that if you see people started on doses much higher than this, I expect a lot of side effects. I'm always a big fan of start with the smallest dose and go up because these meds will work that day. Whatever symptom relief you're going to get in day one. It's just a matter of whether you can detect it and how much a child's natural functioning varies from one day to another. So if you need to increase the dose, you'll get benefit the next day. So there is no rush to make the first dose the strongest dose. You tend to just get more side effects. And as you heard, particularly teenagers aren't a big fan of taking these medicines anyway, so if you give them a lot of side effects from the get-go, they really want nothing to do with it. Little break here. Calvin again, running around, being hyperactive, and then inattentive in the same vein, which is how most kids will present with a mixture of both symptoms. So if your first medicine doesn't respond, figure out what dose you're at. There are rough dosing guidelines based on how many milligrams of medicine versus how much the child weighs. It will not allow you to pick the best dose, but tells you if you're not there, you could probably go up and you might get some effect. But if you're at this level, you're just going to get more side effects. So we have some rough parameters to give us a range of doses that might be viable. So if you're not at a dose, if you have some room to go up, you can go up. Going up increases the effect while the medicine works. It doesn't so much make the medicine last longer. So if the parents complain of symptoms after 6 o'clock and your medicine only lasts till 6 o'clock, generally increasing the dose isn't going to help you a whole lot. What you have to do then is figure out a way to either switch to a preparation that lasts longer, or on occasion we may piggyback shorter acting doses on top of each other, although we always try to prefer to use one med one time a day. If you're having side effects, it's really a matter of figuring out when it is. If it's happening when the medicine is working, you probably have too much medicine. But one of the most commonly reported side effects is that my kid gets real hyper at the end of the day. That's not so much a side effect. That's the medicine wearing off at the end of the day, and things coming back. So again, it's something to prepare parents for, that all these medicines end probably by 6, 7 o'clock at night at the latest, because we need to be able to sleep too. And it's not good for kids to have stimulant in them throughout the day. But that means you might have to move your schedule a little bit. You might have to move homework up earlier, or you might need to move dinner back a little later, or even bedtime back slightly later, depending on how old the child is, if you want to get full effect and good tolerability of these medicines. What to watch for that could go bad? Sleep, appetite loss, stomach aches, headaches, irritability, small changes in blood pressure, tics, the meds wearing off, and simply not taking the medicine. So the number one side effect is noncompliance. Your kids, and even adults, don't stay on these medicines. Partly because they're an everyday medicine. No one's good at remembering an everyday medicine, whether it's for asthma or blood pressure or ADHD. Secondly, it's a disorder of forgetfulness, so that seems like a natural recipe for bad compliance. Third, most of our pediatric patients aren't self-referred. They're not coming in asking for help. And then, in fact, they're relatively unaware of their difficulties and not overly accepting of them in many cases. So it's not surprising that everybody comes off the medicines typically within 6 months of starting them. So the art to getting these medicines to work is working with the kids and getting them to find some value in taking the medicines as much as it is picking the right medicine. I'll talk about tics quickly, because in the 70s and 80s this was considered a big no-no. There's still these big black bold warnings on these medicines. A tic is simply a repetitive muscle movement or a repetitive sound. Typically it's an eye blink or a twitch of the neck, a little movement of the head or neck. They're not medically dangerous, but they can be socially embarrassing. The severe form is Tourette's, where you can very, very rarely get things such as repetitive swearing or whole body flailing over and over again. The vast majority of tics are nowhere near that. We used to think that these medicines cause tics. Turns out that what happens is the impairments in ADHD set the brain up to have tics. So it's really the ADHD that's the driving factor behind the tics in many cases, because about 1 in 4 boys with ADHD will develop simple muscle tics. And then they'll outgrow them as they go through puberty. The trick is they tend to come on around age 7 or 8. And when do kids start their ADHD medicines? They start them around age 7 or 8. So there tend to be more co-occurring things than something that's causally related. But at the end of the day, if you have a child who does tic and you give them ADHD medicine, there's a 1 in 4 chance of making the tics worse. Weirdly, there's a 1 in 4 chance of making the tics better, and half the time the tics don't change at all. So it's something to be cautious for, but it shouldn't prevent one from using these medicines unless the tics are really severe. Substance abuse. Dr. Pelham is here. Maybe he'll comment on this a little bit later. There's always been a concern about giving someone a drug when they're young to help them succeed, particularly something that's classified as a controlled substance med, which means if I want to alter it a little bit and do fun things like crush it and snort it, I could get a high. What's the ramifications of giving a developing child those types of meds? So this has been something that's been tracked very carefully, because people have argued that treating ADHD effectively with the meds might prevent substance use, and people have argued that the medicines might induce changes in the brain that would promote substance use. The best answer so far, unless Bill wants to disagree with me, is that most of the studies have shown little correlation between medication use and drug and alcohol use in your 20s or 30s. In the last 2 decades, the thing that's changed the most with these meds is kids are exposed to much larger amounts of them. And the question is, what's the long-term ramification of that? A lot of these studies date back to earlier treatment when the overall exposure over a decade of childhood was much less. So the place where that's most noteworthy is growth. The most common side effect with these medicines is they make you less hungry. Unfortunately for adults, that's fairly temporary, so they're not very effective weight loss medications.
Which is interesting, though. That's how Adderall was originally approved as a weight loss medication 50 years ago.
Yes. Yeah, some of these are directly derived from their experience in weight loss. And 1 or 2 of them are still looked at on occasion for obesity. But for kids, there are a subset of kids who continue to maintain their appetite suppression, and we're not sure why some do and some don't. The problem is if you're a developing child and you're not eating like you're supposed to, you're not gaining weight like you're supposed to, it might slow down your growth. We used to think just like adults get their appetite and weight back, all kids would get their appetite and weight back. But it turns out with modern dosing patterns, giving these 7 days a week, cutting through dinner time now, you can see some growth suppression. So if you use the meds from age 6 to age 18 when you're done growing, you can be up to about 1 inch shorter for having used the medicines than if you never used the medicines. And that's important, and it's up to a parent, in my opinion, to decide if the medicine might be worth 1 inch. Because what I value as 1 inch may be much different than what other people value as 1 inch. But it's important for parents to know that. And in fact, many practitioners nowadays still think there's no effect on growth. Now, if you stop the medicine while the child's still growing, it looks like pretty much all the growth will catch up, although we don't exactly know at what time, what age you have to do that. So we can't give you a precise level. There's been some concern in the past about heart effects. They are stimulant medicines. They increase heart rate and blood pressure slightly. And for a few people, they may increase it dramatically, although that's pretty uncommon. There was a big brouhaha a while back about should every kid get an EKG prior to going on a prescription like Ritalin. And the answer for that was pretty much the answer for contact sports. Should every kid get an EKG before they go play football? And the answer is theoretically that makes sense. But in the real world, it doesn't really identify people at any greater level than if you don't give EKGs. But that being said, we should listen to their hearts. And even as a psychiatrist, I still have a stethoscope, and I do that. And I'll read EKGs. We should ask parents about family histories of early onset heart problems. And we should ask their parents about, did this child have any history of chest pain, dizziness, short duration during short endurance during athletic events that might pick something up. And if we have any concern, then we should get an EKG. And if it's abnormal, they should go to cardiology before starting the medicine. But consensus now is you don't routinely need to give everyone EKGs because it just doesn't seem to help pick up more cases of concern. There's always a concern with anything that works in the brain. Could it backfire? And could we make people more moody or irritable, which is typically not why parents are coming to us. But again, you have to remember these medicines all wear off within a day. So at the end of the day, the side effects, the benefits are going to go away. So if my medicine was helping a child to be less oppositional, at the end of the day, they're going to be more oppositional. than when the medicine was working. So it often looks like the medicine is creating worse behavior, but typically that's the medicine wearing off. Although that being said, there are a few kids who can react paradoxically to these medicines, particularly if they're very young, particularly if they have autism, mental retardation, or another significant brain injury. They're more likely to have adverse reactions. Although healthy, normally developing children, a small percent of them may have them too. If you stop it, the behavior and the mood should go right back to what it was the very next day. And there's some data from preschool kids to support that. We tend to have more side effects in younger kids. Irritability and moodiness were one of the most common side effects. And these kids seem to experience more weight loss and possibly a little bit more slowing in growth. So you need to be very careful with the medicines between the ages of 3 to 6, which is why the American Academy of Pediatrics, I think in part, recommended always use behavioral therapy first, and I certainly would concur with that. Although you can use it, the medicines do work. And that's the same guidelines, so we'll skip that. So why use anything but a stimulant? Why use anything but Ritalin or Adderall or any of the current reformulations of them? One, some people don't respond at all. It's maybe between 15 to 25%. Second, you just can't get it to work at certain times of the day, in the morning and the evening. Unfortunately, that's often when parents have the most problems with morning and bedtime routines, and often homework is done very close to bedtime. Third, some people can't tolerate it. They just don't gain weight. They have impaired sleep. They have too much of an increase in blood pressure, or for kids with marked tics, you like to have other alternatives. And then there's always concerns about what about kids who have serious depression, bipolar disorder, psychosis, although if you're psychotic or manic, you should treat that first always clearly. And there's some concern about risks of stimulants in these areas. And then some parents simply don't want it because they're concerned about misuse and the controlled substance nature. And that's fine. I have no problem respecting, and I always respect parental preference because we have options here. So whenever we're talking about non-stimulants, always remember behavioral therapy. We tend to forget about behavioral therapy when we get focused on medicines, but there's no reason we can't jump back and say, hey, this isn't working, let's just focus on the behavioral treatments. And one of them certainly is a daily report card, but we've covered that already. So just for name recognition, atomoxetine, branded as Strattera, was the first non-stimulant to get approved for ADHD. At the same time, was approved for kids and adults. It's actually the first medicine ever approved for adult ADHD. It's a little less efficacious. Think of an antidepressant or an antibiotic. It takes several weeks to work, but when it works throughout the day. It can cover into the evening or the morning. The problem is half the people respond to it reasonably well, and for half the people it does absolutely nothing. And you have to wait 4 weeks to find that out. And especially if you're used to a stimulant, if you're crossing someone over, almost all the patients will tell you this stuff doesn't work because they want a response in the first day because they're used to it. So you have to be patient, and you generally would do this over the summer because you're going to have several weeks of unmedicated or unbeneficial effect till you get to potential effect. And that can be problematic during the middle of the school year. Intuniv is the newest of the new, and unfortunately, the newest of the new is always the most heavily marketed, and this is what parents hear about, and they come in asking for it because it's on TV or the ads are there in the pediatrician office. These are actually old school blood pressure medicines. They've been around for decades. They just were repackaged and got approval for ADHD. They do work, but again, you have to take them every day. They take several weeks to work. They're a little less effective than traditional meds like Ritalin and Adderall. And sedation can be a big problem. So you can give them at night, and they can kind of wrap around and work in the morning. But dosed in the morning, you have to make sure kids aren't sleepy. And also, it can lower blood pressure, so we have to watch for dizziness and stuff like that. But they're a reasonable choice for kids who can't tolerate them. And the latest thing is, and it's the first time this has happened, and we're curious to see what the effect of this is, the FDA has now approved combination treatment for kids with ADHD, meaning you have a combination of 2 meds that have been studied and found to be more effective than one med alone. So it's this Intuniv and related meds added to a traditional med like Ritalin. And we're starting to see large uptakes in kids taking 2 meds, which both of these meds have heart effects, so you have to be cautious with that. And they can both have emotional effects, and we don't really know what the long-term effect of this is, but it can work. So if you're really stuck, and even behavioral treatments aren't having additional benefit, there is some evidence now that you could combine meds, although that's certainly not our preference. What else has been used? There's old school versions of the same Intuniv that work. They just last 4 to 6 hours, so again, that isn't going to get you to the school day. Modafinil, marketed as Provigil, is a medicine for narcolepsy, which lots of college students know is the thing that keeps you awake really, really well. That has some ADHD effect. Wellbutrin or bupropion, an antidepressant. It's also marketed as Zyban for the quit smoking drug. It has a little bit of ADHD effect. And then some older antidepressants from the 70s that have some benefit, just like they do for depression, but they have lots of side effects that makes them tricky to use. Antidepressants don't work. That's fairly straightforward. Unlike the cartoon, Prozac isn't going to help anybody's ADHD. It might help mom's stress levels, but it's not going to help their ADHD. So what are the problems? What are the limits of meds? We've mostly talked about this, but just as a reminder, doesn't normalize functioning. It works only really when the medicine is taken. Some kids don't respond. Doesn't affect several key variables in life, such as organization, family problems, peer relationships, and at least not dramatically. People don't take them long term. Parents aren't very satisfied with medicine alone, at least when you ask them what they would prefer. They tend to rate medicine alone as a very bottom choice. And there's been some risk about we may stop too early then. We may quit at the medicine and be happy with our symptomatic improvement and not do the things that we should do otherwise. So like working with parents, there's only so much you can do if you don't work with the parents. So I think since we're going to talk about multimodal treatment, and I really don't want to emphasize mixing drugs, I'll just say again that there's been some studies now looking at that. The only thing I'll end it with this is there'll always be a question about antipsychotic medicines. We got it yesterday. They are very effective medicines, things like Risperdal and Abilify, for improving impulse control and aggression. And they will work in ADHD as well. The problem is the side effect burden, which you're dealing with rampant weight gain, changes in blood sugar, cholesterol, lipid profiles, which have, we know, clearly long-term effects. So you're seeing adolescents with obesity and cholesterol problems. You really have to monitor that carefully and decide if that's worth the benefit you may be getting in aggression when there are other effective treatments. And they should never be gone to as a first or second choice, in my opinion. You going to switch to your computer now?
Yeah, let's switch. Can that be switched back?
So what we're going to shift to now is talking to a little bit about how to integrate the modalities. What are the benefits of looking at behavioral treatments and pharmacological treatments together? And how should kids start? How should you think about starting? What's the risk and benefits of starting with behavioral therapy first, then transitioning to medicine, or vice versa? Because that's really practically what makes a difference, because all of these treatments are effective. The question is, what's the difference between combining the two or starting with one versus starting with another?
So, so this basically says that medication separately the intervention separately, they may fall short. In general, it also may be that what Jim was just saying, that medication helps attention, and behavioral treatments may help peer relationships and parenting, for example, and the combination of something that helps attention and something that helps parenting and peer relationships might be good. So you might affect multiple domains from doing that. As Jim was saying, it's hard to take stimulant medication late at night if you have problems late at night, so teaching parents parenting skills can be a good additional combination. And then this is, I think, the potentially biggest reason for combining treatments is that if our goal is to go from here to here for a child, that's a long way to go with one treatment. That may mean that you need to use a high dose of medication to get there. May mean that you need to use a very intensive behavioral treatment, and for behavioral treatments, intensive translates to expensive. More therapist time, more intensive services, special ed versus regular ed, and so forth. But if you could get halfway there with medication, and then with a low dose of medication, for example, and then the other half of the way with a low dose of behavioral treatment, you might get where you want to go with less problematic in terms of side effects medication and less expensive in terms of cost and actual effort required to do it, behavioral treatment. So the combination of the two might be good, and it might be a real big reduction in cost, and it might be a real big reduction in dose for medication. So that's the main reason to think about this. That's basically what I just said. So what does the literature show? The literature does show actually that when you combine treatments, you do get a bigger bang for the buck. I'll show you a slide that explains that this depends in large part on the dose of each of the treatments that you put together. And Jim, you already went over the MTA, right?
Briefly.
So we're going to skip the MTA, and I think you said all of these things there. I will point out mainly that that one of the things that the MTA study showed was that for the children who were in the combined treatment condition, that is the behavioral condition plus the medication condition, they didn't need or require any increase in the dose of medication over the year that they were in treatment. But the children in the medication alone condition needed a 25% increase in the dose for the year that they were in treatment in order to prevent there being a loss of effectiveness. So the advantage in the MTA of combined treatment, one of them was that you didn't have to increase the dose over the whole course of the year, presumably because of the presence of the behavioral treatment. And you already showed these slides. And then Jim said, did you show this slide?
We only talked about it briefly.
So he mentioned this. It just shows how parents feel about behavioral versus pharmacological treatments. This is from the MTA study. Would the parent recommend the treatment they got? People who got medication alone were generally happy. 2/3 of them would recommend it or strongly recommend it. The strong recommendation wasn't really high. That was not nearly as good as the people that got behavioral treatment. If you just got the behavioral intervention, you were far more likely as a parent to say, yes, I'd recommend that to other parents. And then the combined intervention was a little better than this and a whole lot better than that. So you add a lot in terms of parent satisfaction by adding in the psychosocial treatment. So the current literature, the summary of what Jim said and what I said about psychosocial and combined is this. They both have a solid evidence base. Combination of the two treatments. Remember I said 300 studies of medication, 175 studies of behavioral treatment, 25 studies of combining the two. So much smaller database for that. Way more than lots of other things people have tried, but still pretty small. So in the MTA study that Jim described, intentionally used high doses of both treatments. There are a lot of reasons for that, but high doses of both treatments. So it leaves open the question of what about lower doses that are much more common in real world settings. And
Sequencing.
yes, sequencing. So that's what this this says. So let's look quickly at two studies. And this is how the treatment should be. How should the treatments be sequenced, basically? Should you start treatment for a child, as the AAP recommended? Should you start treatment for young kids with behavioral treatment? I agree with Jim. I think that's a good idea. I don't know that it's data-based. I'm glad that the AAP recommended it. And I disagree with the AAP's recommendation that you should start treatment for adolescents with medication. So the question's wide open. There's only one study that's looked at it, and we'll tell you about that now. In addition, what's the best dose of treatment? As you see, we'll talk about a study that looks at different doses. We don't know a lot about that. And the whole point for you anyway is how do you decide what the best dose is of both treatments for the one child standing in front of you? Not what the literature as a whole means, but the one child you're talking about. Why might it be important to use behavioral treatments first? Well, behavioral treatments have much lower side effect profile than medications do. So if you're talking about decreasing risks overall, starting with teaching the parents how to praise more makes more sense than giving a psychoactive drug to a child as the first treatment that you try. And this may be a problem. If you give medication to a child, you may reduce the parent's incentive to get involved in behavioral treatment. And you may reduce the teacher's incentive to get involved in behavioral treatment. If a teacher talks to a parent and says, go to your doctor, get a prescription for Concerta, it will really help him, the teacher knows, based on past experience, that that child's behavior is going to be dramatically improved. The teacher won't have to do anything in the classroom to deal with the problems they're currently dealing with because the medication will do it. And whether we like that or not, whether we think that happens or not, as people that work in school districts, it does. That's the main way kids get medicated, and that's a potential problem. Okay, we already talked about this. So I'm going to describe actually just two studies. I'll just do SRP and adaptive. Okay, so following the MTA study, we got funded to do 4 large studies over the last 10 years, and I'm going to just describe 2 of them. One is a dosing study that compared different doses of behavioral treatment to different doses of medication and combined treatment, and the other is a sequencing study saying, is it better to start with behavioral treatment or better to start with medication? It's an actual study of that. Okay, so this is a large study that involved 154 ADHD kids who came in for a study in the context of our summer program. So they attended a 9-week summer camp and summer classroom setting, but they were all in a study. And in the course of that study, every child had 3 weeks of no behavior modification, 3 weeks of our regular high-intensity summer program. I described that to you a little earlier, what all the different components were that went into that very intensive treatment. And then 3 weeks of a watered-down version of the summer program, where we took out a lot of the more complex components so it would be easier to implement from a variety of perspectives. So we took out the point system, for example. From the study, we decreased the amount of rewards the kids got. We changed a lot of things to make a lower intensity behavioral intervention. So every group of children had this for 3 weeks, this for 3 weeks, this for 3 weeks. And across different groups of children, there were 12 children in each group. Each group got a different order of those 3 interventions over the course of the summer. Okay? Now, then we did what we have done for years. We laid medication on top of that.
So, and with this, you know, all the medicines are blinded, so the kids didn't know whether they were getting a real dose or a fake dose, nor did the parents, nor did the counselors working with the kids who would be basically, in essence, doing our ratings and observations. And all these numbers predict is this is a traditionally lower dose than we would use in standard clinical practice. This is a fairly traditional dose, and this is a fairly high dose, but comparable to what many kids got in the MTA. So you're looking at a lower than usual, a typical, and a higher than usual, and a completely fake or placebo dose.
Okay, and that was changed for each child every day. Each child's on a different medication regimen, and it's all randomized. So this is a perfect design for looking at the effect of behavioral treatment, the effect of medication, and mixing the two together. This, by the way, was a very difficult condition to implement, because what that meant was the staff were prohibited from using any behavioral interactions with the children. They could not praise the kids, they couldn't set contingencies, they couldn't take away points, they couldn't use timeout. Their job was to keep the kids on site without hurting one another or anybody else all day. And that's a difficult thing to do. Anybody who's had 12 ADHD kids together all day knows that that's a difficult task. The staff at the end of this study said that we should have done a stress-induced drinking study of staff working with ADHD kids. Anyway, so it's a very difficult study to do, but the results are fascinating. We also had, by the way, 72 kids with no ADHD who were in the same groups, distributed across the groups. Those were our gold standard kids. We wanted to see, can we take our ADHD kids with treatment and bring them to the same level of functioning as kids that didn't have any ADHD? They didn't get medication. They were in the same groups, so they got the behavioral conditions, but they got no medication.
Right. So instead of just relying on a rating scale and using 0 on the rating scale as the endpoint, we could simply count how many times a child without ADHD violated a rule in a classroom setting, and that's our normal. That's what we wanted to see how well the treatments brought the children with ADHD to.
Yes, so we looked at lots of different things, and I'll show you just a couple of examples. So when they're in their groups during recreational activities, so when they're playing soccer with all the children in their group, and the counselors are supervising, and all their behaviors being tracked, we're counting, in this case, how many times they were non-compliant to a staff request. We counted how many times they violated rules, how many times they name-called and teased other children, and so forth. all the results look very similar. So I'm just showing you one graph of noncompliance. And just so you can see what I meant when I said no BMOD was difficult, this was on placebo days, that is no medication. That is 30 noncompliances in 5 hours for each child. So 30 times they refused to do, they didn't do what the counselor asked them to do. That's pretty high on placebo days. With the behavioral condition, went way down, so it goes down from 30 to 5 when you implement the behavioral treatment. To our surprise, the low-dose behavioral treatment was actually pretty good. So we had expected this to be halfway between the high-intensity treatment and no treatment, but it was much closer to the high-intensity treatment. The other thing you can see is that a very low dose of medication actually had some benefit, but not nearly as much as a higher dose. But then once you got to this level, you didn't add much by doubling the dose. So going from 36 milligrams, for example, of Concerta to 72 milligrams of Concerta didn't add much. And when you're in the condition where you got both behavioral treatment and medication, so these conditions, more medication added relatively little to your treatment. So if you're getting a low dose of behavioral treatment and a really low dose of medication, you're actually functioning pretty well. And you don't get much better if you add in 4 times as much medication, which has many more side effects. This is where we want you to go. This is where the normal control kids are. And that's still pretty good. And if you're in the high behavioral condition, then the only dose of medication that gives you any additional bang for the buck is the lowest dose. You don't get anything when you double that dose and then double it again. So the point of this is that medication had clear effects, behavioral treatment had clear effects, and the effects are about the same. So the difference between this and this is actually a little better than between that and this. So high dose medication, high dose BMOD, effects about the same. But the really interesting thing is the combination of the low doses. The other thing about this is that at this dose in the study, there were no side effects at all. No child had a side effect rated by his parent or his teacher. He didn't have heart rate or blood pressure increases.
Nothing of concern that would make us adjust the dose or stop it.
All of the side effects occurred at these 2 doses. And the jump from here to here was really high in terms of side effects. So that suggests that maybe we also didn't have appetite suppression here. So growth problems might not occur if using a really low dose in this range, which you can get away with as long as you combine it with a behavioral intervention. So that was looking at noncompliance when they're with their counselors. And this is same children in the classroom on the same days in the same study. And you see the shape of the curve is relatively similar. And also you see that's 60 rule violations in a 30-minute observational period per kid, times 12 kids. 720 rule violations in 30 minutes. So with no behavior modification and no medication, the kids were terrible. And that was the whole point of this study, was to see what they were like when we took away all of the intervention. And that's important because most studies in the real world setting take away medication, but they almost never take away behavioral treatments, because you can't tell a teacher in a real school setting to stop having rules in the classroom and to stop enforcing school rules. So this setting allowed us to do a study where we could make sure we had 0 behavior modification and 0 medication in this condition up there. So let us do a real fair comparison of the 2 modalities of treatment. Okay, and if we looked, it looks a little different. Well, let me just ask, are there any questions about this graph and the one before? Because this is the best study of combined treatment and comparative dosing of these 2 approaches in kids.
There's 2
Yes,
questions.
Dr. Hosa?
With ADHD kids, is it combined subtypes?
Yes, oh, good.
Only kids and
Good question. The study included any ADHD subtype, but almost all of them were combined subtype kids. Relatively few inattentive subtypes were in this group.
You weren't allowed, you didn't have enough of them to do separate analyses to see if there was any differences?
No, but that's a good question. Question back there?
And the low behavior mod was DRC only?
Oh, the low behavior mod was a variety of things. Remember, the kids are in the camp still all day long. The counselors could not do the point system, but they still interacted with the kids. We controlled how, it's really hard to take an adult in that context and say, you can't say anything positive to a child. They couldn't do it. We piloted this to see how it worked. But we were able to control the rate at which they did positive things with the kids and make sure that they didn't do a higher rate than other people have shown as normative in those kinds of settings. So they interacted with the kids positively, but they didn't go overboard and do high rates of praise and high rates of appropriate reprimands and so forth. They didn't do social skills training every day. Instead, social skills training was done once a week in the evenings when parent training happened. In the regular STP, they do social skills training for 10 minutes prior to every recreational activity. So we cut that out entirely. And I would say that the children hated once a week social skills training. They hated sitting there for an hour and having somebody talk to them about being friendly, nice, and fun, which is what we did in that setting. So, and we used a real simple timeout system, much simpler than typical. So we watered down a lot of the different aspects of the program. And the goal was to try to make one that could be done in a school context or other community context with fewer staff members with less training. That was our goal. And surprisingly, it was pretty close to the high intensity treatment. Okay. A little different result if you looked at how much seat work they completed, but not a whole lot. The slopes just aren't quite as different. So again, the red line is pretty close to the black line, and those are both better than the blue line, which is the medication alone. So this is a very good study, and we've already said all these things. We also had the parents going through the same study, so we control what the parents were doing with the kids at home, and the results are somewhat similar for BMOD. The numbers, I mean, the bars are hard to see, but this is no behavior modification. This is a high behavior modification and the low behavior modification. And the difference between high and low for the parents was parents could only give a reward at home once a week in the low dose condition. They could do it every day in the high dose condition. So even parents were able to manipulate this. Why do we think there was less of a difference between no BMOD and the other conditions? We think because the parents simply didn't comply with what we told them to do. So we would say, okay, this week you can't reward your kids at all. And you can't be as positive as we taught you to be last week. You have to withhold it. And parents, they didn't tell us they didn't do this, but I think they just thought, well, if I don't tell them and I go ahead and do it, then at least I'll have a good week. So we didn't have a good manipulation check there. Anyway, all this shows, this is a very complicated slide that basically shows this, and that is that parent preferences are rarely for medication only. So this is parents saying, okay, you've experienced all these different conditions your children have in this study. Tell us which one you would like to have last for the next year. It's just a 9-week study in the summer. And nobody picks med only. 25%, 30% pick BMOD only. A lot pick combining BMOD with the low dose, and a lot pick combining BMOD with the high BMOD with the dose of medication. Okay? So everybody picks combined treatment or BMOD alone. Nobody picks medication alone. That's similar to what happened in the MTA study. Okay, we're going to skip this study because of time. We'll go straight to the last study.
Do you want to show the one slide about continuation? Because I think one of the most common critiques of something like this is when you pull kids out of the research setting, this may all work well in a specialized setting, but does this have any practical application during the school year? Can you take 2 seconds maybe to comment on that?
Okay, so After that study in the summer, parents could re-up to do a follow-up study. And they could participate in the follow-up study if they agreed to have their child go back to school but not be medicated. And we were going to evaluate them every 2 weeks, all year long, and ask how they're doing. We asked the teacher and the parents. If the parent ever said, or the teacher ever said he needs more treatment, then we put him back on medication. So it's a survival study to say, Jim hates this analysis, but how long did you survive before you went back on the horrible medication? Right? So it's how long would you exist back in school without going back on meds? Very simple design. So we just started started half the group on follow-up behavioral treatment. This was very simple. A daily report card established with the teacher. That was it. Plus the parents could come in once a month if they wanted for a booster group parent training session. On average, parents came in twice over the 9-month period. So really, this was a daily report card at school that the teacher did, and that was it. And then these kids got nothing in addition. Now, they had all received the summer program in the summer prior to that. We evaluated every week or two, and then if they were not doing well, we put them on medication. So what this shows is survival. So what this means is the lower, when you get down here, you die, essentially. So these are kids. Each one of these is a child. That's a child who, at the very beginning, in the BMOD, no BMOD condition, that's a child who died. That is, his parent or teacher, his teacher, because this is the school slide, said he needs something more. So this daily report card you guys set up for him is not enough. He needs to go back on medication. And so this was those kids all year long, except these were people who didn't get the behavioral treatment. These are people that did. These got the daily report card, these didn't. So what you see is that just a simple daily report card for the school year kept about 70% of the kids off medication for the year, if they had never been medicated prior to coming into the study. Even these kids who weren't getting a daily report card did fairly well if they'd never been medicated prior to coming into the study. About 35% did well. However, if kids, before we ever met them in the summer, were coming into the study medicated by their physician, then the survival was much less. So almost every child who was medicated prior to coming in and then got assigned to no follow-up from us was back on medication by the 20th week of the school year. Now, the interesting thing is we looked at every variable we had to try to predict why this happened. And we can't find anything except previous medication. We can't find any differences in severity of the kids functioning, no differences in parenting style, parenting skills, nothing. Just if you're medicated before the summer, then you're more likely to go back on medication in a study. And we found that every single study we've done. And it has nothing, and whether you're medicated, by the way, prior to coming into us, has nothing to do with how severe you are or any parenting factor at all. And I think what it is simply, way back when the kid first got medicated, did the parent go into the school when the teacher complained? Did they happen to go to their physician? Did the physician that day happen to say, you should start taking medication? And they got on medication. And no other variable was able to predict that, but once that happened, that really drives what happens thereafter with medication. So this is an interesting result. If you look at the home part, it's also interesting because this is school medication. We have people who were never previously medicated at home prior to starting the summer study. This is interesting.
So
here.
just to explain that means that you weren't using a medication preparation that would typically extend beyond school hours, so something that wouldn't last more than 8 hours a day.
Yes, the study was done. Part of what we're doing here is trying to find out how low we can go with dose of medication. So we intentionally used formulations that did not require that we medicate for the entire 12 hours of the day. So we didn't use Concerta, for example. That's required. And what this shows is that if you had never been medicated before the summer, and your parents came to parent training in the summer, and you got assigned to have a daily report card in the school year, one kid, I think, got put back on medication. So what that means is that those parents learned enough in parent training to say, I don't need to put my child on medication because I learned a lot about that. Now, the graph we just saw showed that a number of those people's kids were on medication at school where the parent can't control it. But at home, these parents felt like things were pretty much under control. And the parents who had the option of coming for the group parenting sessions were much more likely to stay unmedicated than the parents who didn't have that option. The average parent only used it twice all year. So something about knowing that you have that support there if you need it help parents keep their kids off medication. And again, same thing here. If you've never been medicated at home before, and then look at the nature of the drop-off if you've been medicated before. So that's why I think a very important concept to get across to primary care physicians is once you medicate a child, you're changing everything for the future. You're changing a parent's willingness to get involved in treatment. You're changing a teacher's willingness to get involved in treatment. So it's a very, you should think very carefully about that decision. Okay, so that leads, we're going to skip this. So we're going to go straight to sequencing treatments here. The AAP guidelines that we reviewed earlier say for adolescents, do medication first. For very young kids, do behavior therapy first. For elementary age kids, they don't give any recommendations. They say preferably do both, but they don't tell you which one to start first. You want to say anything about ACAP guidelines?
I just think the point of the slide is to show you that there's some differences in opinion. As you go across the different professions in the different countries, you get different responses as to whether both treatments should be started simultaneously, behavioral treatment should be started first, or medication should be started first. So in part probably because there had been very little study of this before. It's coming down to personal opinion and individual experience that drive these guidelines.
Yes, so for example, when I talked about evidence-based practices yesterday, I was talking about one thing that highlights the whole field of evidence-based practice is scientific studies. And until the study we're about to describe to you, there's never been a study of sequencing. So there were no guidelines for how to do this. These were professional guidelines and decisions people made by getting together in groups and talking, but no studies showing whether you should do one or the other first. Okay, so we did a study. We got funded to do a study in which we randomly assigned children to start with behavior modification or to start with medication. And because of the study we just showed you with all those lines and graphs, it showed that the low dose, a really good treatment appeared to be the low dose of behavior modification and the low dose of medication. We thought we'll start with those two interventions. We'll randomly assign people to get a low dose of behavioral treatment or a low dose of medication. The low dose of medication was 0.15 milligrams per kilogram per dose twice a day for school hours. And the low dose of behavioral treatment was 8 sessions of group parent training and a teacher daily report card at school.
And again, practically what that means is that we used an 8-hour capsule, like a Metadate, CD, or Rationale, at basically the lowest available, commercially available dose for most kids, and didn't change the dose during the first 8 weeks.
So in contrast to the MTA study, which used a year of parent training, on average 40 sessions per family, almost a third of those individual sessions. This was 8 sessions of parent training and 1 visit to set up a teacher daily report card. So very low dose and low cost behavioral treatment, and then this was the low dose medication. And then we treated people for 8 weeks, and then we evaluated how they were doing. We asked the teacher and the parents, and we looked at an objective measure of how they were doing. And if they're doing fine, they just stayed in that whatever they started with. If they're not doing fine, then we flipped a coin again. And if the coin came up one way, we said, okay, you started off with behavioral treatment. Now we flip the coin again, you need more treatment, you're going to get medication added to your behavioral treatment. Or if the coin came up, if that was heads. If the coin came up tails, we said, okay, you started with behavioral treatment. We did a low dose of behavioral treatment. Now we're going to do more intensive behavioral treatments. That's what you get to the parents. You said you needed more treatment. That's what's happening to either the parent or the teacher, depending on whether it was home or school that was the complainant. And if somebody started with medication and they were not doing well, we flipped a coin again. You either got higher dose of medication or you got behavior modification added in. So what this study does actually is it mimics what anyone has to do in practice. You have a kid in front of you, you have to say, okay, I got 2 treatments, which one should I start with? If he's doing fine, then you don't ever worry about changing. You just keep doing what you started to do. But if he's not doing fine, if he's an inadequate responder, then you have to decide, do I up the dose of what I started with, or do I add another modality in? So that's what every clinician, every teacher, everybody has to do for an ADHD child in front of them. So it was very interesting. It was a fun study to do because it mimics what people do in clinical practice. So I'll give you the answer first and then show you some of the data. The answer is, to our surprise actually, you're better if you start on behavioral treatment. It's really hard to do a study where behavioral treatment beats medication because medication takes effect very quickly, has big effects, so forth. But this study showed if you started in this condition, you did better than this condition on the primary outcome measure. The primary outcome measure was direct observations of the child's behavior in classroom setting, and also teacher ratings, which is a secondary outcome measure. At the same time, we learned a couple of other interesting things. This really surprised me. I don't know about you. Nearly half the kids who were in this condition got a very low dose of medication, and the teacher never said they needed more. That was, what, 46% of the kids? Something like that.
Almost half, yeah.
Yeah, and that shocked me because that was such a low dose. I thought, well, at 8 weeks, they're all going to say he needs more medication, and if not then a month later they're going to say he needs more, or a month after that, because the kids got reevaluated every month all year long, and if they ever needed more, then the coin got tossed again and they got re-randomized. So that was a real surprise to me. Was it to you?
It is, in part because our diagnostic assessments include measures of impairment. So one could argue that you're picking kids who minimally meet symptom criteria. For example, if you had a whole bunch of inattentive type kids and you were mostly keen on behavioral observations, but that really wasn't the case. These were still largely combined type kids with a fairly typical symptom profile. So they weren't inadvertently or intentionally mild in presentation.
I think what that means is that one potential implication is that most of the kids in the country who are medicated, who typically start at a higher dose than that. The starting dose is what? 10 for many kids in primary care?
Well,
10.
I think debatably, some physicians will start at a full dose, which again, I'll argue there's really no need to because you can escalate doses quite quickly because the effects onset within a day. What it may mean is that it's once you provide a medication, the medication becomes responsible for any individual behavior of the child. So, and we know the medicines don't resolve all the symptoms. So a child who was oppositional and argumentative and inattentive and hyperactive, you start the medication, and then any of those behaviors become reflective of the lack of effect of a medication, which isn't the case. But the second there's a problematic behavior, it creates this need to increase the dose. So the doses increase as a reflexive response because you started a treatment. And you may push past and kind of miss really sustained therapeutic effect that, and teachers are comfortable putting up with a low level of symptoms.
So here's the outcome, just showing that you have significantly better classroom behavior. And this tells you where the differences were. Remember, when this study ends, you have 6 groups of people. You have the people up here and the people here who did fine in whatever they were originally assigned to, and they just stayed in that arm of treatment. Then in each of these arms, you have 2 other people who got increased dose of what they started in or got the other modality added in. So you have 6 groups. This graph tells you, in terms of this outcome, rule violations per hour, how those different 6 groups contributed to that outcome. And there are a couple of interesting points. First of all, people who were not re-randomized, they're low, they have low violations, But that's by definition. We checked all year long. Teacher always said, no, they don't need anything else. So those kids are doing well. So if you started with behavioral first or medication first, for 40 to 50% of the kids, the teacher said, hey, they're doing fine with the treatment, so they don't get more. If you had people who started with medication and had medication added, as opposed to people who started with behavioral and had behavioral added, so they're getting escalated dose. Medication plus medication, you're pretty good, but you're actually not as good, and this surprised me, as people who started with behavioral and then got some more intensive behavioral. This level is lower than this group over here. The biggest surprise is that if you ended up getting the coin tossed such that you had the other modality added in, so what you end up getting for the most of the year is combined treatment. So these people who end up getting combined treatment, both psychosocial and behavioral, for the rest of the school year, they started with medication. These people ended up getting combined treatment for most of the school year, but they started with behavioral, and they are much better than these guys. So if you're going to get combined treatment, what this study shows is you're better off starting with the behavioral than you are starting with medication, even if you end up in the same condition for the vast majority of the school year. So why did that happen? We think this is why it happened. In the re-randomization, if you were started in medication and then you didn't do well, so you got the coin tossed, you got re-randomized to get parent training. Turns out that a lot of parents never came in for parent training. So the attendance at parent training in BMOD first was 98%. You randomly assigned to get parent training at the beginning of the study. Everybody came all the time. If you were randomly assigned to get BMOD, but you had started with medication, and then the coin toss puts you into BMOD after that, only about 40% ever attended on average. Okay, a huge decrease. And when we looked at whether you attended booster sessions, it was even a bigger increase.
Right.
So almost.
And if I remember, I mean, this is a research study, so this is designed to promote attendance. These are evening sessions with free childcare. There's no cost for parking. So the only impediment was transportation and the time commitment.
Yes.
And there was no cost for the services, obviously, because it's part of a study.
Yes, so this is a giant difference. And we think that's one of the reasons here, because many of these parents never even came in for the session with the therapist to tell them how to back up a daily report card at school. That is, how to provide a reward for a daily report card at school. So the intervention wasn't as effective because the parents never came in to get it. It really was surprising because they're in the study. They all knew that. It was easy to do. So acceptance of behavior modification was dramatically affected by what you started with. Acceptance of medication wasn't. I mean, almost everybody, if they got re-randomized to have medication added, said, fine, I'll take that. So it didn't hurt to start with BMOD in terms of later uptake of medication, but it did with medication in terms of later uptake of BMOD. So we've already gone over the results of that. So that's the only study that exists on sequencing of treatments. I think it shows very clearly that you should start with behavioral intervention, not with medication. The outcome is hard to argue with. Direct observations of rule violations in the classroom in their regular school setting, wherever that happened to be. And it showed that you get really good outcomes with low doses of treatments, way lower than people typically do. Really easy to do for a classroom teacher, 8 sessions of group parent training for a parent, and low dose of medication with very few side effects for kids. So that's the only study like this. So how do you make this decision, and what's your take on that?
Well, I think once you start to put this in the real world, again, it becomes an issue of accessibility and feasibility. What this tends to, I think, really push a point across is if you're a clinician and you have access to both routes of treatment, it's important to recognize that the parent's initial treatment selection really drives what they're going to do in the future, much more than the child's individual presentation, which is what we'd like to think, but that isn't the case. So it's not only about what works best right now, but it might be about what will work best in the long term and what people will access. So as a physician, this puts me in the position of really trying to want to encourage people to attend behavioral sessions, but having worked in primary care settings and worked with many pediatricians, I can respect all the impediments as to why they don't do that or find it very hard to do, because those treatments aren't at hand. Anyone can write a script quickly. The training level for pediatricians is much higher for medications than it is for behavioral treatments, mostly, and still nowadays. And if you wanted to find a specialist, it's debatable. Either one of those can be very hard to find in settings, particularly one that would be accepted by someone's insurance. So that creates a lot of complication, and I think data like this is helpful to try to affect policy decisions, but until policy decisions are impacted, I don't know how much real-world change we'll be able to induce.
And what I would say about that is, the nice thing about this is the behavioral treatment was very low cost. 8 sessions of group parent training cost almost nothing. And setting up a daily report card with a teacher does cost nothing. And so it's in big contrast to our summer treatment program, which costs way more than that. But this shows that a very low dose of treatment was very effective, even when combined with a low dose of medication. So in terms of services now for Medicaid reimbursement, for example, or for the Affordable Care Act, this is a low-cost treatment. In fact, we've just finished analyzing the different costs. Turns out it's also cheaper for the arm where you start with behavioral treatment than it is for the arm where you start with medication. It's far less expensive. Can you figure out why? One of the most expensive costs in the study is the cost of medication. In fact, this study is done with the current generation of medications as opposed to short-acting generic methylphenidate, so they're much more expensive.
That's the other big shift, which doesn't necessarily, it impacts some parents individually. In the 70s, 80s, and early 90s, everything was generic. That's pretty much all that there was. Nowadays, with extended release preparations, most of them are branded, and even the ones that are generic have one company that make them, so I call them a pseudo-generic. There's a minimal cost savings with them. So from a societal level, the cost of medication treatments have gone way up. The meds are improved, but the cost is significant as well.
And the other thing to keep in mind about this is if you're school personnel, you're school people, then you should keep in mind that if the first thing you do is to tell the parents to go to the pediatrician to get medication, then you're actually decreasing the likelihood that the parents are going to get involved in the things you want them to get involved in school. If on the other hand you said, we'd like you to get involved in some things in the classroom, and if that doesn't work, then we'd like you to go to your pediatrician and get medication, you're much more likely to get a good outcome and cooperation from the parent. Okay, so how do you get this going with an individual child? One of the things that we've done for years and have neglected to tell people really clearly is that a key to this whole study, this entire study, was setting up a daily report card for every child. That is, having the teacher identify the goals for the child in the classroom and set up a little way to measure those goals. And we've done this for years, and it turns out that that's what we use to decide how much medication a child needs. Because if these are for this child, if the teacher says, these are the goals that he needs to reach to function better in the classroom, then that's much better than a symptom checklist for making a determination about what treatment he needs, because the teacher said these are his problems in the classroom. So if you set up a daily report card and you do it right, then you can actually try different medications on different days or different weeks and look at the success on the daily report card as your best index of how this child's responding to treatment. And that turns out to be much better than a rating scale. So if you set this up, this is what you use to decide how the child's doing, when the medication's enough, and then you can stop going up with medication. You end up with a dose that maximizes his performance on the functional outcome measures that the teacher has identified, which typically include academic functioning and peer functioning in the classroom, and behavioral functioning in the classroom.
I mean, you'll contrast to this to what is probably the most common practice. Someone comes into the parent comes into the pediatrician, everybody started a med, pediatrician asks, how's it going? And that's how you get school feedback. They ask the parent. And if you're lucky, you have a report card. You might have a very basic behavior chart for a younger child. Putting the effort in to get this established, I have always found incredibly helpful to evaluate the effect of medication. in that it's therapeutic in and of itself, so it does decrease the dose. It allows you a more practical day-to-day sense of measuring the medicine. And then you don't have to try to get the teacher to fill out additional rating forms, which in and of themselves cost money. So having this in place previously does impact the ability of the medicine to be assessed and probably to work as well.
So this is the key to starting treatment right, because we just told you in the last study, so start with behavioral treatment. This also is the tool that you use to decide how much medication the child needs and whether he's a good responder to medication. So it's real key, and there are a whole variety of ways you can do that. Do you want to say anything about those in 2 minutes? That is whether you do it a week at a time.
You can do complex procedures. I mean, in the end of the day, the problem is not so much that the kids try harder when they're on real med or fake med. It turns out the kids' own sense of their expectations doesn't change much, whether they know they're on med or not. What happens is the parents and the teachers, their perception of how well the child behaves changes a lot, whether they know they're on med or not. So you're not even so much need to blind the child, but it's helpful to blind whoever's rating the child's behavior if you really want a genuine effect. But the effects of the medicines are large enough and instantaneous enough that you can usually find it without doing things like blinding the dose so nobody knows what it is. But practically, in terms of assessment, you probably, you'll always want to start low. And if you want to be thorough, you can try a couple range of doses. But typically what we're doing is comparing one medicine versus the other. And the nice thing is with stimulant medicines, you can take an Adderall product one day, and you could probably, in most instances, prescribe a Ritalin-based product the very next day, certainly from 1 week to the next week, if not. And you can get a pretty quick comparative sense, but only if you have a reasonable measure. And that's, again, where the daily report card comes in. If you just ask parents how this week go at school versus how that week go at school, you're lucky if they've talked to the teacher, and then the teacher's probably going to reflect on yesterday, not the week as a whole.
So here's an example of what you get. This is one child's daily report card where the teacher said, did he complete assignments within a given time period? This is no medication days, low dose of medication, higher dose of medication. That's what you end up with. It's really clear. You want that to improve, so whatever dose gives you the improvement on that is good. So this is, and we have on our website at FIU, a downloadable packet on how to establish a daily report card for a child that a parent can take to their teacher and set it up. We also, I think, have a downloadable packet called How to Do an Outpatient Medication Assessment, which tells you how to do this sort of evaluation for a child. So
this is something, it's not necessary to come to our summer camp to have a med evaluated, but for kids in the camp, we can routinely do this, and we can really parse out the effect of individual medicines. And when you get kids coming in on complicated multiple meds per day regimens, you can quickly, in many instances, figure out that they don't add a whole lot over single dose regimens, but only because you can get the repeated observations in a naturalistic classroom setting.
okay, so behavioral and pharmacological treatments are the only two evidence-based treatments for ADHD. Behavioral treatments teach skills. That's the whole point, is teaching skills to parents, teachers, and children. Medication has to be continued for long-term change, but so do behavioral treatments. They both have to be maintained if you're going to expect long-term changes to occur. Whether the combination treatment is going to result in better long-term outcomes has never been studied, so we do not know whether it will.
And I encourage families to think of this as diet or blood pressure control. We can all lose weight, but typically if we don't stay in a program, we tend to gain it back. Because having someone remind us the certain behavior changes that promoted getting our result is very powerful. And then certainly the same thing with blood pressure for blood pressure medicine. If you take a blood pressure medicine for a year, it'll keep your blood pressure down, but your blood pressure will probably creep back up over time if you don't take it. It's really no different to think that ADHD medicine would be anything different.
And then the third bullet says parents prefer behavioral treatments to medication. We showed you several studies that document that. The next one says if you start behavioral treatments first, 50 to 75% of the kids don't need medication. Fewer than that at school. So more kids are going to need it at school. Remember the two graphs we showed earlier? More kids are going to need it at school than at home. And the doses are going to be dramatically lower if you start with behavioral treatment, which means lower side effects. Right. Both now and in the long run.
Most side effects are dose dependent. While you don't clearly always get better effect by dose once you cross a threshold, traditionally you will get increasing side effects as you go up by dose.
And when you combine the two interventions, you get better acute effects. you get lasting behavioral effects if the medication is withdrawn. So you have better residual effects in the child if you've been doing behavioral treatment if medication is stopped. And they're preferred by parents and teachers. One reason that's very important is parent preferences are what impact what's going to happen in the long run. So if a parent likes the treatment they're getting, likes the involvement that they have, they're going to continue to do it, and it's that continuation that may be critical for long-term outcomes. And there are big individual differences in response to both treatments, so you need to do what we were just describing with each kid. So you set up a daily report card that's tailored to that child, and then use that to implement and titrate your medication and to implement and titrate your behavioral treatments. And this said there are few studies of dose effects and sequencing effects. There's one study of multiple doses of medication and behavioral treatments, and we just showed it to you, and there's one sequencing study. So this is all cutting edge stuff, and come back in 10 years and maybe there'll be some more studies. Thanks so much for your attention, and we're happy to take questions from the hardy final crew.